The title of this lecture is Intrapartum Fetal Monitoring. The learning objectives for this presentation are number 1, to understand the 3-tier classification of electronic fetal heart rate monitoring. Number 2, to review the effects of electronic fetal heart rate monitoring on clinical decision-making and outcomes. Number 3, to learn potential management strategies for Category 2 and 3 fetal heart rate tracing. First, I'll review the background. Fetal heart rate monitoring is modulated by the fetal brain. The fetal heart rate is determined as a balance of the parasympathetic and sympathetic tones. EFM can be used to determine fetal oxygenation. EFM is limited by poor inter and intra-observer reliability, high false positive rates, and uncertain efficacy. The frequency of EFM utilization has increased from 45% in 1980 to 85% in 2002. Specifically, the inter-observer reliability of fetal heart rate tracing interpretation is poor at 21 to 29%. It is greater if it is a normal tracing. If the fetal outcome is known, the interpretation is likely to change. Please remember the classification of fetal heart rate tracing is dynamic. The classification can change depending on the clinical scenario and management. An important aspect of EFM includes uterine monitoring. We must assess the contraction frequency, duration, intensity, and relaxation time. Normal uterine contractions are 5 or less in 10 minutes averaged over a 30-minute window. Tachysystole refers to more than 5 contractions in a 10-minute window averaged over 30 minutes. Tachysystole refers to both stimulated and spontaneous labor. The terms hyperstimulation and hypercontractility should not be used. When there is tachysystole, you must indicate the presence or absence of fetal heart rate decelerations. Next, we'll review the 3-tier classification of fetal heart rate tracings. Category 1 is normal. It strongly predicts normal fetal acid-base status and no intervention is required. Category 2 is indeterminate. There is insufficient evidence for the tracing to be Category 1 or 3, and thus it requires close observation. There may be need for ancillary tests or intrauterine resuscitation to ensure fetal well-being. Category 3 tracings are abnormal. They require prompt evaluation and treatment. There must be prompt delivery if treatment does not improve the fetal heart rate tracing. The Category 3 heart rate tracing is associated with abnormal fetal acid-base status and requires management such as maternal oxygen, position change, cessation of labor stimulation, and treatment if tachysystole is present. Let's review the EFM definitions. First, the fetal heart rate baseline is determined by rounding the fetal heart rate to increments of 5 beats per minute over a 10-minute window for at least 2 minutes. Normal is between 110 and 160 beats per minute. Tachycardia is defined as greater than 160 beats per minute. Bradycardia is defined as less than 110 beats per minute. Next, we look at the baseline variability. This is fluctuations present in the fetal heart rate amplitude. The amplitude is measured from peak to trough in beats per minute and are usually irregular in frequency. Persistent, absent, or minimal variability is a sign of fetal compromise. Absent variability shows no change in amplitude. Minimal variability is 0 to 5 beats per minute change in amplitude. Moderate variability is 6 to 25 beats per minute change in amplitude, and this is the normal baseline variability that should be observed in a fetus. Marked variability is greater than 25 beats per minute change in amplitude. Heart rate accelerations are an abrupt increase in the fetal heart rate. The onset to the peak of the fetal heart rate occurs in 30 seconds or less. If the fetus is greater than 32 weeks in age, this increase in fetal heart rate must be at least 15 beats per minute higher for 15 seconds. If the fetus is less than 32 weeks in gestational age, the increase in fetal heart rate must be 10 beats per minute for 10 seconds. A prolonged acceleration is defined as an increase in the fetal heart rate that lasts for greater than 2 minutes but less than 10 minutes. If the acceleration lasts for greater than 10 minutes, then it is defined as a fetal heart rate baseline change. Sinusoidal patterns are a sine wave-like pattern with a frequency cycle of 3 to 5 per minute for greater than 20 minutes and can be a sign of fetal compromise. A deceleration is an abrupt decrease in fetal heart rate. A prolonged deceleration is a decrease by 15 beats per minute that lasts for longer than 2 minutes but less than 10 minutes. If the change in heart rate is greater than 10 minutes, then it is a fetal heart rate baseline change. Decelerations are defined as early, variable, or late. Early decelerations are a symmetric decrease in fetal heart rate for greater than 30 seconds with the nadir of the fetal heart rate occurring with the peak of the contraction. A variable deceleration is an abrupt decrease in the fetal heart rate for less than 30 seconds. The decrease is at least 15 beats per minute for 15 seconds. A late deceleration is a symmetric decrease in fetal heart rate for greater than 30 seconds, with the nadir of the fetal heart rate occurring after the peak of the contraction. Please review the following figures in order to visualize the difference between the early, variable, and late decelerations. An episodic deceleration pattern is not associated with a uterine contraction. Variable decelerations can be episodic. Periodic deceleration patterns are associated with uterine contractions. These include both the early and late decelerations. Variable decelerations can be periodic as well. Now, let's review the three-tiered EFM interpretation. Electronic fetal heart rate monitoring should be reviewed every 30 minutes in the first stage of labor and every 15 minutes in the second stage of labor. Category 1 tracings have a normal baseline of 110 to 160 beats per minute. The variability is normal or moderate. Accelerations can be present or absent. Early decelerations can be present or absent, but late and variable decelerations must be absent. Category 2 examples include tachycardia or bradycardia without absent variability, absent variability without recurrent decelerations, fetal stimulation with no accelerations, minimal or moderate variability with recurrent variable decelerations, moderate variability with recurrent late decelerations, a prolonged deceleration greater than 2 minutes but less than 10 minutes, and variable decelerations with slow return to baseline. Category 3 tracings include a sinusoidal pattern or absent variability with recurrent late decelerations or recurrent variable decelerations. Medications can affect the electronic fetal heart rate monitoring. Narcotics can lead to decreased variability and decreased frequency of accelerations. Butorphanol can lead to a transient sinusoidal pattern in 75% of patients. However, the sinusoidal pattern in this context was not associated with adverse fetal outcomes. Butorphanol can also increase the baseline fetal heart rate. Cocaine can lead to decreased variability. Corticosteroids can lead to decreased variability, and effects are seen after 29 weeks of gestational age. This effect returns to normal after day 4 to 7. Magnesium sulfate can lead to decreased variability. It inhibits increased accelerations with increasing gestational age. The decreased variability that is noticed may be a reflection of the gestational age and not the magnesium alone. Terbutaline can lead to an increased fetal heart rate and the rate of tachycardia. Now I'd like to review the resuscitation for Category 2 and 3 tracings. First, a cervical examination can be used to evaluate for rapid cervical dilation, umbilical cord prolapse, or descent of the fetal head. Next, you can assess for an acceleration after fetal scalp or vibroacoustic stimulation. Vibroacoustic stimulation is the application of a vibratory stimulus to the maternal abdomen in an attempt to induce a fetal heart rate acceleration. Next, you should discontinue labor stimulation. Then, you can change maternal position. Positioning to the right or left lateral recumbent position helps reduce compression on the inferior vena cava to improve uteroplacental blood flow. You should improve hypotension with volume expansion or ephedrine, which can be seen after an epidural. An intrauterine pressure catheter can be placed inside of the uterus to more accurately assess the frequency and strength of contractions. Fluid such as normal saline can be introduced through this catheter into the uterus, which is called an amnio infusion. You can consider an amnio infusion to relieve cord compression with recurrent variable decelerations. Lastly, you should monitor for tachysystole. Next, I'd like to review the clinical applications of electronic fetal heart rate monitoring. Moderate variability is associated with a pH of greater than 7.15. The presence of accelerations reflects no fetal acidemia. Electronic fetal monitoring increased the cesarean delivery rate, and the indication for cesarean deliveries was for abnormal fetal heart rate tracings and concern for acidemia. The risk of forceps or vacuum operative delivery was also increased. Electronic fetal monitoring decreased the risk of neonatal seizures. However, it did not reduce the rate of perinatal mortality or cerebral palsy. The false positive rate for predicting cerebral palsy is 99%. Of note, 60% of women in preterm labor will have non-reassuring fetal heart rate patterns. The ideal method to assess fetal status has not been determined, but the application of accepted fetal heart rate interpretation standards allows the opportunity for timely intervention and hopefully to optimize fetal outcomes. Please read the following journal articles for additional information about electronic fetal heart rate monitoring. Thank you.